Good morning, everyone, and welcome to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for this morning's session, and thank you for spending part of your weekend with us. My name is Jackie Sable. I'm a member of the Echo team, and I'll be facilitating today's session. A few announcements before we begin. If you haven't already done so, please put your name, email address, and affiliation in the chat box. Please stay muted unless you are speaking. If you're dialing in, you can use *6 on your phone to mute and unmute. Otherwise, you can click on the microphone icon on the bottom left-hand side of your Zoom screen. You may also use the chat for communicating. We realize that question and answer time is important to you, and we try to categorize and address as many questions as possible, but we always follow up via email with any open items. If you have suggestions for future COVID-19 Echo sessions, please share via the chat tool or email us at echo@psu.edu. Please remember that no personally identifiable information is allowed when we're discussing cases. We are recording these sessions and always share all materials and recordings afterwards. In the spirit of all teach, all learn, we'll be on a first name basis during the session. For those who are not familiar with Project Echo, our Echo sessions always begin with a brief lecture and are either followed by a case discussion or a question and answer period. Today's session will include a brief lecture by Dr. Gavin Macgregor-Skinner. Thank you for joining us again, Gavin. And he'll be talking about citizen science and how you can help COVID-19 research without leaving the house. And that will be followed by a question and answer period. During the lecture, please feel free to put your questions into the chat. We have a team of specialists from Penn State Health Online, and they will help field questions, but please remember that this is an all teach, all learn, so everyone can share both questions and answers. And with that, I'm going to turn things over to Gavin.
Good morning, everyone. So this morning, I'm going to talk about citizen science, how you can help COVID-19 research without leaving the house. I'm going to talk to you about a definition of citizen science that I use, some examples of infectious disease surveillance epidemiology where citizen science has played a significant role. And I'm going to provide a toolkit on how you can actually design and start your own citizen science program. Or if you don't want to do that and just want to be a participant, what are some of the existing platforms, some of the existing research projects that are out there that you can also join as a participant? Citizen science is where anyone, anywhere can participate in the scientific process, addressing real-world problems in ways that may include formulating research questions, conducting scientific experiments, collecting and analysing data, interpreting results, making new discoveries, or developing technologies and applications, and solving problems. So what does that mean? Well, citizen science is public participation and collaboration in scientific research, and often from the comfort of your home. For my career in citizen science, it started with the work that I was doing in participatory epidemiology in disease surveillance and research. And there's a paper available that was written by my colleagues, Christine Joss, Jeff Mariner, Peter Roeder, and it's available for free on this website. And that paper describes how participatory epidemiology aims to give voice to communities while increasing our understanding of health problems and the options for their prevention, control, and surveillance. And I'd like to show you now some real-world examples of where we've been using participatory epidemiology, crowdsourcing, citizen science for a number of years now in disease surveillance, prevention, and control. In 2007, when I worked for the US government and arrived in Indonesia at the airport, this was the map that was handed to me. And what it showed was that H5N1 avian influenza or bird flu had been confirmed by laboratory test in 30 of 33 provinces. In an island archipelago like Indonesia, it was just assumed that the virus was everywhere and that all the chickens, all the ducks, the birds, as well as some of the humans would just be inevitable, would just get infected. We could control the viral load. We couldn't control the viral transmission. There was no way to stop this. And it was a pretty serious situation because we also believed at this stage in 2007, without control in a country like Indonesia or Vietnam or Egypt or other countries that were experiencing high infectious disease outbreaks of bird flu, that this virus could mutate and become the next global pandemic. So what did we do? Well, what was important here was to get better local intelligence, better local information. And to do that, we took a citizen science approach using our participatory epidemiology principles and tools, where we trained 80 master trainers. Those 80 master trainers then trained 1,200 local regional trainers. The 1,200 local regional trainers then trained 25,000 local coordinators. And what was interesting, once we had this whole team of local coordinators trained at over 25,000, they came back to me and said, we want to be identified. We want to be acknowledged for the work that we're doing. You need to buy us orange t-shirts, which at that stage wasn't on the budget, but we managed to buy them orange t-shirts, like this one here, the MONROVIA disaster team for avian influenza. The way that these teams worked at the local level was through text messaging, both sending text messages into centralized databases, as well as our ability to push out questions and queries and information through text message. The idea of developing frontline workers at the local level to move, they were agile and could move quickly to respond to rumors, myths, or even confirmed outbreaks of bird flu was highly successful in decreasing the viral transmission of bird flu throughout Indonesia. And one of the ways they did this was through community mapping, using participatory epidemiology tools. And in this photo here, this is a husband and wife that are contributing to a map of their location, the area where they live, that others have already contributed to, and they're telling their story. This is story mapping. And they're telling the story of how the disease came, the symptoms it caused in the birds, some of the people who got sick, what happened to them, where they lived. They give it over time and space. So that the end product looks something like this, which gives us a time and space or spatial and temporal analysis of how the virus moved between the different communities, the different villages, the different neighborhoods, in what direction it went. It shows in this map a river. It also shows that there's a mountain on the right-hand side there. And if you look at the community in number 6, the community in number 1 and 2 told us, you need to go visit the community in number 6, which we had no plans to visit because they got it much worse than we did. So using citizens, using a husband and wife and other members of the community, they were able to do a story mapping exercise, both visually as well as telling their story and providing some very critical information in the epidemiology of this disease, and also that we could develop the risk factors and identify what mitigation and interventions will need to be developed to prevent further transmission. And it also worked not just in rural country areas, but also in the city. And this was an exercise that was done in a city where there was an outbreak in one of the suburbs of Jakarta. And the reaction from local government and also federal government was to close small businesses, close the markets down. But by sending in the local coordinators, the community interviews that were conducted, they produced a map like this. And this is really interesting because it shows that the virus, the bird flu outbreaks occurred really in just 3 small areas. And they gave the dates of those areas when chickens were observed with symptoms and were dying. They also showed that there was a truck. And this one truck on this particular day had visited these areas, and it's shown here on the red dotted or dashed lines, the route of the truck and where it went and visited. And it brought eggs and chicken to these 3 houses. But it also showed through our storytelling that there was no connection to the market or other small businesses. And the outcome of this investigation showed that, yes, the 3 areas there were hotspots. They had viral transmission, but it was not related to the market, and it allowed us to, or the government to open up the market much sooner. It allowed small businesses to go back to work, but it also then was a lesson and provided critical intelligence to the community on how this disease spread, Again, it was from the introduction from a truck that came from another area, delivering eggs and chicken. And that may not be a good idea in the future to continue to do that without knowing that it came from a safe or green area where there was no transmission of bird flu. Similar outbreaks of avian influenza or bird flu were happening in Egypt in 2006, 2007. And on a trip that I went to Egypt at the end of 2006, again, the country was just covered in H5N1 or bird flu in 22 governments, 822 communities. And again, the decision was that the viral load, the virus was just distributed everywhere, and it was inevitable. There was no way we were going to be able to stop the transmission of bird flu throughout Egypt. But what was interesting about Egypt was that they already had a citizen science or a neighbourhood program in place where they were mapping the immunisation status in children by household. And on this map here, it shows the colours red, blue and green. Green was a household where all the children had met the requirements for their vaccination or immunisation status. Blue was where some of the children had met the requirements, but there were still some children that needed to be immunised. And red was where there was no children in that house had been actually gone through and had their vaccinations. And so they had no immunisation status. So when there was an outbreak of like measles or other vaccine preventable disease, they knew the households they had to go to first to give the vaccine, but also they knew from this mapping exercise where the high risk families lived. Now they took these principles and they applied it to bird flu, to avian influenza. And they started mapping, again, pieces of paper by hand with markers and different colours, identifying those that had chickens, ducks and geese and had no separation of species throughout the day and the evening, or were unable to cage their poultry, and they were labelled red. Blue was where they had some caging and some separation. Green was where every household was able to separate their poultry and their chickens and their ducks and their geese, but also had built homemade cages for that separation. And from this map here, this gives us a stratification of the risk at the neighbourhood level. It identifies those areas where we need to do some education, some awareness training and some interventions. We need to show the houses that were painted green as being a good example of what to do to decrease risk and prevent being infected by bird flu, and how to translate those really good practices from the greenhouses to the blue houses as well as the red houses. And this was done at every neighbourhood throughout Egypt. It took nearly 4,000 people to be trained and mobilised at the neighbourhood level to get this level of maps produced, but then also to move forward with interventions. If we look at the ZIKA virus outbreak in 2016, when we had babies born with microcephaly or small-sized heads, and the fact that we had a new virus called ZIKA spreading around the world, often the way that the World Health Organization or the CDC or the state health department conveys risk to communities is by colouring in an area the same colour. But we know that this disease spread by a mosquito wasn't all over the US. It was never in Alaska. And so colouring in countries like this is good for indicating where it may be, but it doesn't indicate where it actually is. And it provides a little bit of a sense of risk communication, which is not accurate. We then saw that in Florida, Miami-Dade County, and this is a map that was published by the CDC on their public website on September 7th, 2016, where they coloured in neighbourhoods red. And that really shows and illustrates to the community that if you cross the road and go into the red zone, that's where you get the higher risk of getting Zika and being bitten by a mosquito. Well, that's not absolutely true either. And so the message here was, don't cross the road, don't go into the red zone. So by using tools like Google Earth and other satellite imagery, we could actually identify the buildings, the houses, the space, the land that was in that red area. We could then actually mobilise citizens, the public, to go and actually look for mosquitoes like the Aedes aegypti. Interview people whether they've been bitten recently by a mosquito. Have they had any of the symptoms that were related to Zika? And what made this citizen science project work was that the Aedes aegypti mosquito is very easily recognized. It has these white bands on its legs. So the citizen science projects that were set up was that if you observe a mosquito in your area, in your house, the back of your house, the front of your house, in your neighborhood that has white bands on the leg, then send us a text message. Reply on the app that you've observed these mosquitoes. Other citizen science projects were done throughout the area by catching mosquitoes in glass jars and coating them with the insecticide to see whether there was any levels of resistance. So there's a number of different projects and programs set up that provided very critical research information and data and answered questions done by the public. And so that when we looked at what was inside these areas that were highlighted red by the CDC and by local government, that the mosquito like Aedes aegypti that has weak muscle wings, can't fly very far, wasn't ubiquitous, it wasn't everywhere, it was actually isolated, and there was higher concentrations in certain areas, which then with the limited resources we had to go and do insect control, we could then actually direct those resources where to go on a daily basis. Again, we had limited resources, and it was important that we managed them properly. And citizen science and story mapping played a huge role in that. If we go back to Ebola in 2014, the sharing in near real time was really relied on SMS text messaging. But it wasn't just one company, it wasn't just one organization, it was all these organizations here on the left-hand side, all these teams that had to come together to make this SMS text messaging work across countries like Sierra Leone. And then we had to understand where those that had cell phones and those that didn't. But we also had to map out where there was connectivity and where there wasn't. And you can see on the map on the left-hand side, it shows in pink here the areas that the communities had connectivity and those that did not. And so it was really important that by doing this mapping exercise, using again organizations that were well set up, the government, as well as citizens, we could actually then convey important information through text messaging. And then now, again, we've moved on from text messaging to use apps. And for an example, WhatsApp, which has end-to-end encryption, is yet another fast, simple, secure messaging, again, free, that we can use with the public, with citizens, to pass on, both collect information as well as push out information when we're doing our disease surveillance work. And I want to emphasize that mapping makes the invisible visible. And this again is another example from Ebola in 2014 in Monrovia, Liberia. And when we started seeing outbreaks at the neighborhood level in Monrovia, the maps that we had looked like the map on the left-hand side, the before map. Very little information on population density, buildings, infrastructure. And within 7 days, the citizen science team, the organizations on the right, as well as the citizens, the public, produced the after map by mapping out where houses were, where infrastructure was located, as well as doing a bit more of a census population data analysis. And again, through telling stories and digital mapping, once we had that base map produced, we were then able to go and then do better contact tracing, better surveillance for any possible cases of Ebola. And this was the same approach that we took and this example comes from Nigeria, where we set up Ebola rapidly deployed resilience teams within a Ebola rapidly deployed resilience program. And this was done with the Accordia Global Health Foundation and the Elizabeth R. Griffin Research Foundation, as well as the West African Infectious Disease Institutes, which was a new formed group of 12 universities that had come together. And those 12 universities using faculty as well as students, and we trained over 5,000 students to initially do the contact tracing throughout Nigeria. Because when I was in Nigeria, the 3 Ebola cases that we had 891 contacts, close contacts that had to be contacted preferably twice a day, but at least once a day for 21 days. So it was very resource intensive. And the 5,000 university students that were trained under this program, that's what they did. And then as we move towards looking at how to get disease free in Nigeria, the 5,000 students were used to identify both Ebola free neighborhoods, as well as where there might have been Ebola neighborhoods with likely cases before they were lab tested. So again, we were mapping both free neighborhoods as well as possible cases or hot zones. And that was very important in getting ahead of Ebola to ensure that Nigeria could be declared Ebola free. And that same process was used of citizen science across 14 countries. Now, initially, the World Health Organization had gone into these 14 countries with a team and a survey, and they had looked at the critical mission functions on country preparedness for Ebola on the left-hand side here, 11 critical functions. And they produced a map which relied again on the traffic light system, the red, the yellow, and the green. But what citizen science, the mobilization, the training of these university students did was that we were able to add more questions. We could focus on certain critical missions, but we were also able to add a percentage level of preparedness. So without just saying that you were yellow and not knowing whether you were 40, 20 or 30% prepared, we were able to actually add these numbers there to show and identify gaps in what needs to be done next. And this was really important because we took what WHO was doing was a 1 point and at 1 point in time survey, and we actually used citizen science, the students, the 5,000, or the students that we trained, the university students, to bring in more intelligence, more data on a more regular basis, because this was a very fluid environment where things were changing every day. And so this was provided, again, near real-time information on a daily basis, and it was presented like this on a dashboard for ease of use and understanding. We've seen other dashboards, and this is really important as a lot of citizen science projects rely on dashboards for presentation information, which includes maps as well as graphs. And this was the US Department's Defense dashboard as an example that we used throughout the Ebola outbreaks of 2014, 2015. We're also seeing dashboards now for coronavirus, COVID-19. And this is a COVID-19 impact planning report from Redwood City in California. And you'll see that they've identified those people that don't have health insurance, population and businesses, poverty and language, and they've identified at-risk populations. And I want to emphasize how important within the community engagement, the citizen science, the crowdsourcing projects that I've been involved in, the visualization of data, of information. And we can visualize through maps, such as through Google Maps, Google Earth, or other sources, as well as satellite images. And they're all available free. And that's something that we can use from the comfort of our own home, being able to access both maps and satellite images and put information on there based on the time we got that information, but also the location. So it's important that we can then do temporal and spatial analysis on that data. But it's also important to look at location and how do we identify location? Do we use a GPS latitude, longitude to identify location? We often see problems and challenges of taking 9 numbers that identify latitude, 9 numbers that identify longitude, and putting them into something like an Excel spreadsheet without making any errors or mistakes. And we know that at least 75% of the world has inadequate, poor or no addressing systems, as well as a lot of infrastructure and buildings lack inadequate or poor addressing systems. So here's one example that we've been using for a number of years in disaster medicine that I wanted to share with you. Again, it's free, but it works really well when we go out and do natural disasters as well as infectious disease outbreaks. And that's using an app called What 3 Words. The app is free. It works offline anywhere in the world. It can be downloaded on your computer, your tablet, or your phone. And what 3 Words has done is that they've taken the globe and they've developed a grid of 57 trillion squares. These squares are 3 meters by 3 meters or 10 feet by 10 feet. And when they started, they went to the English dictionary, say it was about 171,000 words in the English dictionary, they only needed about 40,000 words to combine 3-word combinations for all 57 trillion squares. They've now actually produced an app and also on their website, which has translated these 57 trillion 10 feet by 10 feet or 3 meter by 3 meter squares into over 30 languages. So emergency management services, first responders throughout the world have been using now for a number of years what 3 words. For example, if someone was hurt and needed urgent medical assistance in this 10 feet by 10 feet square here, how would you tell them where they were accurately located? What address would they have? By using the 3 words loud, fame, sport, which actually means absolutely nothing, but it's a way of linking to a GPS system which uses latitude and longitude coordinates, we can now accurately find exactly where that person is laying down and needs that urgent care. Something similar was done in Denver, Colorado recently, where fire hydrants, as part of their critical infrastructure, didn't have a physical address. And they used the what 3 words, 3-word address combination to go and identify every fire hydrant throughout the city. And again, this is something that we can easily do within a citizen science project, where we could incorporate either GPS coordinates, latitude, longitude, or incorporate a 3-word address using what 3 words to accurately identify space location. And I want to emphasize that we've been hearing a lot recently about COVID-19 and flattening the curve. And that flattening the curve at the moment is based on positive lab tests, hospitalizations. But in Keller's article that he wrote back in 2009, he mentioned the unstructured event-based reports for disease surveillance. And it's really important that citizen science can actually add value to what does that curve look like through text messaging, blogging, email, internet searching, social networking, internet chatting, online news reporting, video, radio news reporting, as well as the health expert reporting from public health surveillance, epidemiology, lab tests, and hospitalizations. There's a lot of information we have at our local neighborhood level that can really help us understand what is the disease situation within our local community. Again, I want to emphasize that we're dealing with an unseen enemy. We're dealing with the SARS-CoV-2 virus. And it's important that we use the available information, symptoms, signs, vulnerable populations, lab tests. We use those pieces of information to make the unseen seen. And so citizen science, and I want to direct you to this paper by Rick Bonney and Karen Cooper. And again, it's freely available at the website link listed on this slide. They published a paper in 2009 on citizen science, developing a tool for expanding science knowledge and scientific literacy. And it's from this paper that I think that a lot of the conversation, the use of the term citizen science has evolved. There's a lot of citizen science projects out there. Just Google them. They've been done for climate change, environmental changes, a lot of wildlife, bird watching uses citizen science. Again, destruction of the environment, changes in the environment. But it's also been used for infectious disease surveillance, prevention, and control. And from information provided in this document, the US government has created a citizenscience.gov website. And it's a fantastic website. And one of the resources I want to direct you to on this website is their toolkit, their how to do stuff toolkit. It's wonderful. And it outlines the basic steps for anyone who wants to set up a citizen science project. It provides the planning tools, such as step 1, scope your problem. Step 2, design a project. Step 3, build a community. Step 4, manage your data. Step 5, sustain and improve your citizen science project. So I would encourage you, if you're interested in your neighborhood, community level, in doing citizen science, 1, reach out to government, local public health agencies, reach out to the state public health agency or the state government. But also, if there's a question you just need to be answered using crowdsourcing or citizen science, go to this tool because it's really, really helpful in establishing the how to do citizen science so that we know the data is robust, usable, and can be shared with others. So let's look at some examples right now that exist that maybe you don't want to create your own citizen science project. Maybe you just want to participate. You just want to stay in your home and participate and help answer some problem, some real critical question that's important in COVID-19. So how can citizen science help fight COVID-19? Well, there's an app out there called COVID-19 Citizen Science. It was released just recently, and it aims to enroll 1 million individuals for real-time epidemiology. It asks each participant to share the link to recruit at least 5 others. And this is really important because we see a lot of enthusiasm when people sign up for a citizen project, but it's important that we also get a cohort of people that we may know, our friends, our neighbours, our relations, and actually motivate them to stay in that project for a long-term period. And the length for this project is 6 months. They're going to share their data by visualization using maps. You take an initial 15-minute survey, and there'll be follow-up questions either delivered by text message or push notification. And this again, as a source from Greg Marcus, this is what the COVID-19 Citizen Science app looks like. Again, it will ask you a few questions, and then it'll ask you about how you feel and any symptoms. And it has your local government issued or continued any of the following restrictions. And it takes about a minute of your time to do. Another citizen science project that you can participate in came out of the Flu Near You project that was started by Boston Children's Hospital, and they've now developed a COVID Near You app that can be downloaded. You can participate. It uses crowdsourced data to visualize maps to help citizens and government identify current and potential hotspots for COVID-19. And the website is covidnearyou.org. Again, when you go to that website, step 1, you visit the website. Step 2, you can report your zip code and any symptoms you have every day. Step 3 is at the zip code level, you can see others around you that have reported COVID-19 symptoms, as well as those that have reported whether they've been tested and whether their test was positive or negative. The challenge with apps like this is participation. So what we've seen here is that for the past 2 weeks, only 574 people have reported COVID-19 for the whole entire country. And only 386 people have reported taking a COVID-19 test. Not very big numbers. And when I looked at what they've mapped, and this is the map that I accessed yesterday, which showed those that have been reported symptoms and those that have been tested. But when I honed in onto a zip code here, like in the local region where I live in Washington, DC, like zip code 20002, in the past 2 weeks, only one person has participated using this app and reported their symptoms. And only one person, might have been the same person, has reported taking a COVID-19 test. And again, for citizen science to be successful, we need to recruit and get people to be involved and use the apps. And this comes from the District of Columbia, where since the start of the outbreak, we've had over 2,350 laboratory confirmed cases and 81 deaths. So there's a lot more people in the area, even at this zip code level, that could be participating. Again, the COVID Near You app looks like this, where you report your symptoms. You just click on those symptoms that you're feeling. It has a questionnaire. What day did you start to feel ill? Did you see a health professional? How many days have you been isolated? Have you traveled? Were you in contact with anyone? You provide your age, gender, male, female, and your zip code. Another app is Patients Like Me. And here, step 1 is you visit the patientslikeme.com website. And Patients Like Me allows you to share your stories and your data so that you help each other, as well as helping researchers. So things that you can report on Patients Like Me is symptoms reported by people with COVID-19, the treatments taken, where you can compare treatments, and who has COVID-19 on Patients Like Me. So again, that Patients Like Me website is patientslikeme.com. Go and have a look at that website where you can do comparisons down at the local level. The challenge with these maps where participants fill out the information, they'll then see a visualization of that data. So a question that we often get is, I can see on the map that there's a growing number of symptoms and confirmed COVID-19 cases being reported in my area. What should I do? Well, information's available from your local health department, your state health department, the US CDC, but also you could go back and look at the Penn State Project Echo YouTube channel, where we recently did a Get Your Household Ready for Coronavirus Disease 2019 webinar, which will then has a series of 7 steps that takes you through on how to get your household ready for the likelihood of having any cases, any loved ones in your family that have symptoms. So just say you didn't want to do a COVID-19 citizen project, but you wanted to be involved in some sort of citizen science project. Well, there's another website called zooniverse.org, for example. And what's interesting about zooniverse.org, last week, they had 30,000 new contributors signed up. And the volunteers that signed up processed 5 million images, 4 times its usual number. This is really interesting when we put it into the same time frame as the COVID-19 citizen science project apps that we have going, which at the moment don't have a lot of recruitment, don't have a lot of participants, but then people are staying home wanting to do something. And Zooniverse is a website for crowdsourced citizen science projects where, again, you can listen to baby noises. You can transcribe Arctic plant collections. You can help locate black holes. And there's many more interesting projects that you can be involved in. When we're trying to create, like the examples we did in Indonesia, Egypt, and other areas of citizen science projects using participatory epidemiology, crowdsourcing a lot of information, we need coordinators. Just like we saw in Indonesia, where we trained master trainers and then local trainers that went to over 25,000 local coordinators. There's a lot of local organizations throughout the US that could help participate in citizen science projects. One example is the Neighborhood Admins Resiliency Network. Now, this is a resiliency network that was created through using Facebook groups and has engaged thousands of people throughout the country in conversation, but also delivering appropriate infographics and information on how to protect those that may have symptoms, how to decrease the risk of getting infected, and also how to ensure that when you're sick, what actions you should take so that you don't infect others. And when we look at the Neighborhood Admins Resiliency Network as an example, we can see that in many locations throughout the country, the community members the numbers are quite staggering. They're significant. They're large numbers. They provide information to many organizations, be it government or non-government, also businesses. So again, this is one of many platforms that we could engage to roll out the critical citizen project needs that we have right now for COVID-19. I've said this before and I need to say it again. Doing citizen science projects, collecting information, you're not alone. You will not be able to do it all on your own. You need to create partnerships. You need to make friends. Because we need to foster a culture of collaboration. That collaboration is a process where people or organizations of different perspectives come together to solve a shared problem with a common goal. And this is such an important point for a successful citizen science project. So let's look at what are some of the citizen science project questions or needs we need right now. Well, some of the questions that could be answered is, why does the disease hit the elderly so hard? How effective are stay-at-home orders in slowing the virus spread? How is sheltering in place affecting our physical activity and mood? What everyday behaviours or exposures might influence the risk of infection or transmission? So as we implement these projects at the local neighbourhood level, getting people to sign up, now that can be the easy part. but persuading them to keep contributing information is often more challenging. And what we do by having a coordinator of these projects, someone that manages the quality of the data, the implementation, we rely on smaller subgroups, neighborhood groups, friend groups, family groups that can then contribute to the information. Because altruism alone will not make your project a success. We need to give people something of value they wouldn't otherwise have. We need to give them some feedback. And we do that through visual representations, information on the local COVID-19 infections and situation. But with any project, with any research project, collecting data always involves some sort of data areas. And again, with citizen science projects, they can be random or systematic. They can be introduced by the collection of data by untrained or insufficiently trained, or just by people that aren't familiar with collecting data for science projects, such as the volunteers we use. But our study design must account for these areas that we might encounter. And that level of error can be reduced by, again, allowing participants to provide clarifying metadata, or to register uncertainty, or use incentives to reduce sampling bias. Researchers could ensure they have the means to assess the accuracy of the contributed data. So a way of verifying, ground truthing the data in a bi-directional communication technique. So we actually go out and verify that data that was collected by asking some similar questions. May not be exactly the same questions, but it helps understand that the data that we're collecting is robust and is of high quality. So what are the next steps for COVID-19 science projects here in the US? Well, can the methods in citizen science projects be standardized? I think they can. How to maximize citizen science data quality so it can be used by government and non-government as well as the public. Is there a need for guidelines? And this is something we need to think about for the design and execution of citizen science studies. Do we need to have a standardized approach? Or can we actually answer the same question through different approaches? And how should credit for data collection be apportioned? How do we provide feedback? Is there payment involved? Again, citizen science projects, and this is important to understand, provide an access to a wider range of participants than traditional studies. People who have historically been underrepresented in research, people who live in rural communities, people who live in economically depressed communities. It allows anybody, anywhere to participate and provide information. So we've all probably heard and seen the guidelines for opening up America again. And that's going to rely on a lot of data, a lot of new information that we don't actually have right now. It's important that within those guidelines, they've outlined proposed state or regional gating criteria. Symptoms, cases, hospitals, all that data has to show a downward trajectory. They've also outlined core state preparedness responsibilities. The responsibilities are going to be on the state and local jurisdictions, neighborhoods. And an important part of this jigsaw puzzle is that citizen science projects, as we saw in Indonesia, as we saw in Egypt, can contribute valuable information when it comes to contact tracing, for example, and understanding vulnerable populations and better situational awareness. Because the proposed phase approach put by the government is based on up-to-date data and readiness. And a lot of that data we don't have or a means of collection. And this is where citizen science projects are going to be valuable and necessary to collect that data. We're seeing the use of dashboards, and I want to emphasize the value of dashboards, how valuable they were throughout Ebola, ZIKA, as well as how valuable they are for interpreting and understanding information and providing situational awareness for COVID-19. This is a dashboard from Johns Hopkins. Again, it shows the total confirmed cases in the US, over 700,000. It shows the number of deaths. But what we need to do is take this information, as well as those that have been tested, take this information down to the local neighborhood level. It's great at this level, but we need to hone in and be more, and take it down to that more highly defined neighborhood level so that we can actually, as we did for Ebola in Nigeria, create free zones as well as likely zones that have transmission. And only by that can we identify the risk factors and come up with the interventions that are going to decrease the spread of the SARS-CoV-2 virus that causes COVID-19. Other dashboards that we've seen, here's one from University of Virginia. And what I like about this one, they actually have a time slider that you can see here. And that time slider allows you to visualize data that they have collected from January 22nd all the way up to April 17th when I took this screenshot. We're also seeing other visualization of data that's readily available through census tract information and other local government information which can map out the proportion of the population that are aged over 60 years, which is a high risk factor, as illustrated on this map. And then we can take something like the CDC Social Vulnerability Index database, which has 15 social factors for identifying in any sort of disaster or emergency, the resiliency of the local community, and the resources they have to prevent further suffering. And we can overlay it on a population age 60 map, and you can start to see that the risk is different throughout the country. The risk is higher in certain areas. And as we zone in, as we go in, zoom into those neighborhood levels, we'll see where those high risk areas are, and we'll come up with mitigation and interventions on how to protect vulnerable populations. So the citizen science projects that I want to finish up with that I think are needed at the neighborhood level through visualization, through collecting appropriate data that is of high quality, robust. We need to be able to map confirmed active cases and recoveries at the neighborhood level. We need to map the spread of infections. I talked about time and space, but we also need to ensure that we're not just dealing with COVID-19, all those other conditions, medical conditions, diseases, concerns, worries, anxiety that people have also need to be mapped. So again, we can come up with interventions and address. This is all about preventing suffering, preventing anxiety, preventing more impact from just not the disease itself. How do we map vulnerable populations and show most at risk? This is something we can do at the neighborhood level. Map facilities, employees, citizens, resources, equipment, goods and services. We're now seeing in the area where I live, restaurants being open, but not everyone in my neighborhood knew that certain restaurants were open, or certain businesses were open, or where there were certain resources available. We can do that through visualization on maps. Again, any citizen science project that you participate in or initiate will rely on visualizations, and I can't emphasize how important it is to be able to develop maps, dashboards, as well as story maps, which tells the story of how I got sick, where I think I got sick, and maybe who I had contact with, which will then help us as we mobilize not just thousands, but it's going to be millions of people to ensure that we properly do the contact tracing that's required to provide the data so that we can start getting back to a normal life. Thank you, everyone.
Well, thank you, Gavin, for that incredible amount of information and resources. There were a few comments that I wanted to address, and then we'll open it up to questions and answers and any other comments. First, just a reminder, if you haven't seen it in the chat, we will share all of your wonderful resource links and app links via a Word document after the session. Lex pointed out that while he was listening to you lecture, he did check out the covidnearyou.org app, says it's amazing, and he used it, and he's 55 miles north of New York City. First time he's heard of the app, and he's going to urge local officials to look into it. So I'd like to open it up to questions and comments at this point for Gavin or anyone else on our call.
Hey, Jackie, this is Erica. I have a quick question. Can you hear me?
Go ahead.
So I'm curious to know, in the state of Pennsylvania, how I would go about understanding the void of location mapping. Do you understand what I'm trying to ask? I'm wondering how, if there are any spots that we can't map.
That's a good question, Erica. The Pennsylvania government has been using maps. They've mapped, I think it's about 155 hospitals within the state. Those hospitals, we know the physical location, we know the catchment area. From where we know where people live, we can understand from that one map the government's put out, if we go back down to the neighbourhood level, who has access to those hospitals? How long does it take you to get there? What areas of what parts of the population are vulnerable that maybe don't have transportation to get to those hospitals that we know? Because the hospitals don't move, they're there. We know those physical locations, but what we haven't looked at is what is the analysis of the population that may live close by, may not live close by. We can also look at our throughout Pennsylvania, our population by age, by ethnicity, race, again by other socioeconomic factors, and identify those that may have access to resources and those may have not. And again, that will help us then mitigate the spread of this virus.
Does that address your question, Erica?
I will go look for those maps. I think I was, you talked about the app. Was it the one? I'm sorry, I was trying to take notes. What 3 words? I was just wondering if that's necessary for use in the United States, or if that's more of a problem that less developed countries experience.
No, it's a good question, Erica. There's so many things that don't have addresses. We saw the example from Denver, Colorado. How do I tell you exactly where the fire hydrant is? I have to say it's on the corner of this road, near this block, near this. No, if I give you 3 words, it's very succinct. It's to the point. What 3 words was not developed just for a developing world, countries in Africa or anywhere else in the world. We're using it in so many disaster medicine, emergency medical services here in the US, as well as in other countries, to identify those in need and identify them those quickly. So again, there are a number of 911 systems, even in the US, that is now have incorporated what's 3 words into their 911 messaging. Where are you? I'm stuck in the well. Where's the well? It's at this 3-word address, for example.
Thank you.
And I do want to mention that Ellie has had somebody, I guess she has done, captured all of the app addresses, and they are now listed on a Word document in our resources folder. So Rachel said in the case of rural areas, we can have multiple names for the same place, various maps versus local knowledge, to kind of follow up on what Erica had asked and Gavin's response.
And that's a good point, because often when I respond to hurricane, tornadoes, tsunami, earthquake disasters, Jackie, again, I'm going in, I'm not familiar with the area. I don't know what the local names are. And so again, for years we've used GPS coordinates. That's like 9 numbers for latitude, 9 numbers for longitude. How many databases have I looked at and those numbers are wrong, and that doesn't actually give me the location? Now we've got an app, and there's other apps out there. This is just what 3 words is just one example that provides you a 3-word address as well as it's linked to a GPS location. So I get both. And it's important that as we're trying to move quickly, if I'm called to an apartment here in Washington, DC that I'm not familiar with, what 3 words address it by saying, we're at these 3 words on the 4th floor next to the elevator. It tells me exactly where I need to go without the long lines without understanding, is that in northeast, northwest, southwest, whereabouts is that exactly? And I may not be familiar with it. So it's a way of, location is going to be so important as we do the contact tracing, as we provide data. We need to have location or spatial data attached to anything we're collecting to share with government, to share with other organizations, as we show that there are areas that are free of COVID, those that still have COVID, and as we sort of transition in those phases of opening up and getting back to normal.
Thank you. Are there other questions or comments? Feel free to put your either into the chat or unmute your microphone.
I have a quick question. So, I mean, it's pretty clear that this citizen science data has a lot of good uses. What are you seeing in terms of actual use by state and local governments or federal governments? is it being used, or is it more of a sort of, citizen to citizen use case?
No, that's a great question. Citizen science has been around now for a while. Again, in climate change, environmental impact studies, just doing surveillance of birds, migration of birds, citizen science projects have played such a huge and significant role in identifying things. As we saw with ZIKA, the mobilization of citizens through citizen science projects to identify those white bands on the legs of mosquitoes. When we had limited resources, the number of trucks and people that could go out and spray insecticide on a daily basis, the identifying breeding areas played a significant role in decreasing the number of mosquitoes and preventing Zika spread in those states in the south where we activated these projects. What we've seen for infectious diseases, it's so important. And this is when I look at the federal government opening guidelines for America, when I look at what the state governments are now doing, every time I read those documents, the first thing that comes to me, Aaron, is, oh my gosh, we're going to need more data. We're going to need more information, and we're going to need it on a daily basis. That means we've got to scale up to thousands of people that aren't actually employed by local government in the public health department, but are going to have to actually contribute in a way that the quality of the data is robust enough to be analysed by government as well as non-government, and that's going to require a lot of us. And I mean a lot of us. It's going to be not thousands, probably millions of us to participate in these programs to provide information on a daily basis. And that's where that's the pathway we're heading to right now.
Thank you for your question, Aaron. Bill wants to know what, or is there a 3-word address for the Hershey Medical Center? So that could be a test that we all look up.
Bill, that's a great question. I was in a hospital the other day and they had 16 entrances to that hospital. And they were trying to ensure that with their triage for patients with respiratory infections that they were going to be tested for COVID-19, that they go to the right door. I said, but you've got 16 doors. How do you actually tell people when they get to the car park, this is where they need to go? So in that hospital, we're actually using a 3-word address specifically for where the triage area is, so that people don't go through a door with symptoms and start wandering through pediatrics or labor and delivery or some other part of the hospital. So we're using a 3-word address. This is the area where you go to answer questions and get triaged for those that have respiratory infections or respiratory symptoms.
Thank you. Great example. Other questions or comments? We do have a few minutes left of Gavin's time. If not, we can gain a few more minutes on our weekend.
I wonder if Gavin is getting any requests from media outlets for questions about citizen science, or if he's, I'm not familiar with your work, Gavin, but you're a wonderful speaker and very, I would love to see you on CNN or something, even at a local level. Like we at Age Friended Care Pennsylvania, our nurse practitioner just did a piece with WTAJ, which is a local network in Altoona, and we're just trying to get people to stay healthy while staying home. That's kind of our new tagline. So I'm curious to know if anybody's reaching out to you or what kind of media presence.
That's a really important point, Erica. I was very lucky to have 18 days in Hong Kong in the beginning of February, helping Hong Kong hospitals, but as well as mobilizing people. And this was a lot of people, training them to do the contact tracing that Hong Kong needed when they had their COVID-19 cases. And so when I came back from that Hong Kong visit in the middle of February, I was trying to explain what Hong Kong was going through right now, and no one wanted to listen. And this is what we find the challenge with public health all the time, is that when we try to do prevention, no one wants to listen to prevention. When we try to get organized, no one's, but when we have a just in time, we have a crisis and we have to be reactionary, that's when we start going, oh my gosh, I need 1,000 people now to help the local health department do their contact tracing, and I haven't identified who they are, I haven't trained them yet, and I haven't been able to ensure that they can actually do the job that we're asking them to do. Well, what I'm trying to say now is, here I am living in my basement. I don't want to stay here for the rest of my life. I want to be able to get out and get back to what I normally do. So I think it's important we start to put in that infrastructure now. University professors will play a very significant role in developing curriculum, doing the training, providing the mentoring and the supervision to ensure the standards and the quality is high, but then supporting government through, I would see this across the country. We're seeing some universities get involved. I think it's going to be nearly every university will get involved in being a force multiplier in training the local public on how to participate, for example, in a contact tracing program that's going to be so critical to provide the data that government's going to need to make evidence-based decisions.
Thank you for that. Thank you for sharing that. So we have 2 minutes left. If there are any last questions or comments, please go ahead and put them into the chat. While we're watching for those, Gavin, it's always wonderful to have you with us. Thank you so much for sharing your time with us. Please remember that we do allow you to collect CME credits for today. Just complete the survey that comes out afterwards, one survey for each session. Again, all materials are being shared, and we hope you join us for the next ECHO session scheduled for April 20th. That's Monday at 8 o'clock, and we'll discuss research studies for patients with COVID-19. So there are a few more questions or comments in the chat, and I will let anyone read those as they're coming through. And with that, enjoy the rest of your weekend.